Well, thank you, Emma. Thank you for inviting me, and thanks for the introduction. So I'm a physio by background, and I work at a hospital, and part of my role there is to run research trials. So I'm going to talk about running a research trial from the perspective of an NHS employee. I wouldn't say I'm an expert in trials. I've been involved in steering committees of various trials, data monitoring committees of various trials, supervising some PhD students running some trials, and I've done some feasibility trials myself. So I'm going to talk about an example of my feasibility trial, and talk about hopefully some trial design ideas or options, some of the regulatory requirements involved, some of the practicalities of what's involved of running a trial through an example. I think one of the main differences between some of the sort of theory around running a trial and running a trial in the NHS is it's about getting stuff done. So you've got to be somebody who has an interest in running a trial or getting involved in running a trial, and have an interest in the problem that it's trying to answer or the question it's trying to answer, and really driving that forward. So you've got to be able to get stuff done, and that's one of the big tips, I would say. So, bit of background of my example. I'm a physio. I work in outpatients, and I'm interested, or one of my interests is in patellofemoral pain. So what is it, and why am I interested in it? Patellofemoral pain is pain around the kneecap, so around the front of the knee. You might hear it be called anterior knee pain, and primarily people get it when they're in a weight-bearing position when their knee is bent. So stairs, getting in and out of the car, bending, squatting, and of course any type of sport or activity or running. It's really, really common. So about 23%, so one in 5, 1 in 4 of the UK population, adults, will experience this type of knee pain or have it at any one point. So it's really, really common. And typically, these patients will get referred to physiotherapy. So physio departments across the country will routinely have many of these patients coming through the door, patients with anterior knee pain. And current treatments for it aren't spectacular. Only a third of patients will report being pain-free a year after diagnosis and treatment. And reoccurrence is really high. 90% of patients will still complain of pain and problems 4 years later. And typically it results in people reducing their activity levels. So 75% of this patient group will drastically reduce or stop participation in sports or activity. And we know that being physically active is really good for us. So they will drastically reduce and stop. And if we compare the pain levels to other diagnoses in the knee, so the KOOS, the knee injury and osteoarthritis outcome score, is typically used as an outcome measure for trials looking at knee pain. So the top line is typically our pain-free individuals when measured on pain, stiffness, function, sport and recreation, and quality of life. We look at people with a diagnosis of knee osteoarthritis waiting for knee replacement surgery. Those are the mean scores for the KOOS. People with a diagnosis of knee osteoarthritis on the waiting list for knee replacement surgery, but with confirmed meniscal tears, that's typically their mean KOOS. And then when we now compare that to people with a diagnosis of patellofemoral pain, which is typically people in their 20s and 30s, we can see they have comparable pain and symptoms to people on the waiting list for knee replacement surgery. So it's really common. It's typically in younger adults and really high levels of pain and dysfunction. Current management for physiotherapy is largely variable. There's no standard approach or standard practice. Everyone does something different. The majority of physios would advise their patients not to exercise if it was painful, and a third of physios would advise the patients not to do any sport or activity if they experience any pain. So actually, almost encouraging that avoidance of activity. So I developed a complex intervention, looking at a psychologically informed intervention for people with patellofemoral pain. It involved 2 systematic reviews, a literature review, some qualitative interviews, and some PPI workshops to develop a sort of a psychologically informed intervention for patellofemoral pain. It's called the kneecap intervention, a cognitive approach to physiotherapy for patellofemoral pain. And it involves 3 main elements: pain education, so an education package around contemporary model of pain. Exercise prescription. With physios, we prescribe exercise, but exercise prescription, but based on that contemporary model of pain. So actually it was encouraging the patient to maintain activity levels and exercise through certain levels of pain. And self-management advice around sort of self-efficacy and keeping levels of general physical activity high. So fairly different to usual physiotherapy. Trial design. So I developed this intervention. So obviously I thought it was brilliant, and I thought we should be implementing it across the NHS or go straight to a randomized control trial. But actually there's different ways of answering the question about whether that intervention is effective or appropriate, and how we might go about answering that. So trial design. So there's an observational studies where we can observe a patient group and measure what happens to them over time. So typically they might involve long-term effects of, say, air pollution or smoking, for example, and measure what happens to them. There's a randomized control trial, which assesses the efficacy of treatments or the safety of treatments, usually through randomizing participants to one treatment or another. There's crossover trials, where you have one group of participants and they might get different treatments at different time points. So treatment A first, then treatment B, or another group might get treatment B, then treatment A. Cluster randomized control trials. So you don't randomize the participant, you would randomize groups. So for example, you might recruit GP practices, and any patient or participant at that GP practice would get one treatment, and a different GP practice might get a different treatment. So you randomize the sites of recruitment rather than the individual. Adaptive trials. So similar to a randomized control trial, but actually you do interim results along the way, and you adapt and change the methods and the intervention delivered. Or case control trials, maybe where you're comparing certain groups to people without the condition. So for physiotherapy, in this patient group, we might take people with patellofemoral pain, measure stuff, strength, movement, maybe some patient-reported outcome measures, and compare them to pain-free individuals to see what factors we might find. And then sort of a subset of that, there are ways to think about randomized control trials. Do you do the stats to show that your treatment is better than another one, or do you show that it's the same or no worse? Maybe you have a new treatment that's you think is cheaper, but maybe won't produce better results, but are cheaper. You might want to work with a statistician to do equivalence and non-inferiority trials. There are pilots and feasibilities, which again is a subset of randomized controlled trials. A pilot, maybe you're testing your procedure before you run a randomized controlled trial, or a feasibility, you might be showing that certain elements are feasible before you then invest in a full randomized controlled trial. And then you have pragmatic trials where you're trying to maybe create clinical practice in a sort of real life scenario of how it might work, rather than a clean trial where everything is protocolized. So I developed this intervention, and as I say, I thought it was brilliant. So my instinct was to say, well, let's do a randomized control trial. Let's recruit as many patients as we need, compare this new intervention compared to usual care, and let's see whether it is effective or not. But actually, there's loads of questions before that. So why is a feasibility study needed? There are questions about actually, is this really a big problem? Do we need to invest £1 million worth of taxpayers' money to investigate physiotherapy for this condition? Is it really a big problem? If we're going to compare it to usual care, what is usual care? We need to really work out, how is this patient group currently treated, and how does that compare to this new intervention? If we want to run a large randomized controlled trial, we need to be able to recruit participants. Does this patient group allow themselves to be recruited into a randomized controlled trial? Will they allow themselves to be randomized? Is it feasible to do that? This intervention, if it's wildly different to usual care, can we recruit physiotherapists to deliver that care? Will they be happy to be trained in this intervention and deliver it? Can we collect data to the participants? Are they happy to collect data? Will they send data back? How would we do that? What are the outcome measures that are best to be used, and how do we go about collecting that? This intervention is again, as I say, wildly different to usual care in that we encourage them to keep active through levels of pain. Are patients happy to do that? Is it acceptable and tolerable to them? And if we're training the physios to educate and train the participants, how do we go about training them? What are the barriers to training the physiotherapist? What's the feedback from our education package about how we train the physiotherapist? So all these unknown, all these uncertainties before we might even think about designing a randomized controlled trial. Adam Gordon did a great talk on this series a couple of weeks ago on grant capture and writing grants. So if you haven't seen that, I definitely recommend getting it on YouTube and asking for the link. So again, the assumption is that we've written a grant application and we've got funding to do this trial, and on the back of that, there are ethical principles of conducting NHS research. So there are regulatory requirements. To do NHS research, you need a sponsor. So it would usually be an NHS trust or a university, typically your employer, and they would agree to sponsor you and sponsor this trial. To do NHS research, you have to get HRA, so the Health Research Authority approval and ethical approval. The Health Research Authority have guidelines on the ethical framework for conducting research. They have a UK policy framework for health and social care. It lays out your obligations to comply with the research integrity framework. We have to adhere to the Declarations of Helsinki, which is an international ethical guidelines on how to conduct research on human participants. To do NHS research, you have to be trained in good clinical practice, which is a training package designed to show competence within the HRA framework and the Declarations of Helsinki. You will have to show your certificate to your sponsors, and we have to adhere to the GDPR data protection guidelines. So to do research, there are this extra level of regulatory requirements, particularly with NIHR funded research. And then general requirements. Any NIHR funded clinical trials, you need to register it with a trials register before you recruit your first participant. The idea with that we're about showing open and honestness about the trial procedures. So you would agree your protocol, publish it, or register it before you recruit your participants, so that you agree on your outcome measures prior to doing the trial, and then it holds you to account when you then publish your results. All research involving NHS patients, staff, or resources have to have ethics. Participants have to have informed consent. So consent has to be obtained. There has to be written information about the procedures of the research to the participant. They have to have an opportunity to ask questions, to have a period to reflect on their participation. They have to be allowed to be able to withdraw without any negative consequence on their care. And you have to show that you take patient safety and welfare into account with provisions for monitoring, safety, adverse events. And you have to have trial oversight. So you have to have oversights of the trial with sort of an external governance, usually with a trial steering committee. For larger trials, you might have a separate patient advisory group or a separate data monitoring committee who advise the sponsors, who advise you running the trial, and advise the funders on their external opinion and feedback on the running of the trial. So lots of things to think about. So in terms of my example, for this feasibility trial for patellofemoral pain, I got the NHR funding to conduct this feasibility trial in April 2016, so a few years ago. We developed the protocol in the middle part of that year, publishing the protocol in the International RCT registry on the 19th of December. We got ethical approval on the 7th of November, and that involved 21 controlled documents. So every letter that I was potentially going to send out to the participants, every patient-reported outcome measure, all the consent forms, or the patient information leaflets. We had to produce a draft of those documents in a controlled. They're called controlled documents. So you date them, version them, and you sign the documents, and that involved 21 documents. And then we had HRA, so the Health Research Authority approval, on the 22nd of December. And then the sponsors gave me the green light in January 2017 to start recruitment. So there is a procedure for developing the protocol, getting approval, getting sponsor approval, all before you can recruit your first participant. Any trial is part of a team. You would never do it by yourself. It's always part of a team, whether you're leading or running that trial, or whether you're helping involved in other people's trial. And typically that would involve the chief investigator, so the person who has the overall responsibility for the conduct of the trial, complying with ethics, patient safety, and leading the research. That's the chief investigator. If it's across multiple sites, you would have people at different sites taking charge of that research. So they would have the overall leadership for trial conduct at that site. They would be the principal investigator. Typically, you would have co-investigators, so people helping run that trial with certain expertise. If it's a PhD study, you will have supervisors and experts and mentors assisting in the execution of that trial with expertise and analysis. You would have people at the site helping deliver that research, so research assistants or clinicians. So for my trial, we trained, I think, 10 physiotherapists to deliver the intervention. We had physiotherapists on site helping to identify potential participants. We had department managers agreeing to help facilitate running the trial. So lots of people helping run the trial. We had clinicians who were trained to be research assistants to help collect data and monitor the fidelity and the safety and the adverse events that occurred during the treatment and the trial. Research nurse, so the Clinical Research Network, changed their name recently, help fund research activity. So a research nurse might be involved in the trial, helping recruit and identify participants. And then from a trial oversight point of view, you'll have data managers, statisticians, trial trial managers or clinical trial monitoring. For smaller trials, that might be organised by the sponsors. For larger trials, you might want to work and collaborate with a clinical trials unit, who are organisations that have expertise in delivering and collaborating and running clinical trials. Most universities have them. At the University Hospitals of Derby and Burton, we have a clinical trials unit at the hospital. And so for large trials, you will want to work with them on the process of developing your grant so that they're all costed in accordingly. They all are collaborating on the project and helping to deliver and run that research trial. You will have quality assurance specialists who will be involved in compliance and audits and ensuring that all the regulatory requirements are adhered to. On top of that, the trial sponsors will be involved in the oversight of the trial management, contracts. You'll have the external governance of the steering committees, and I said you might have a separate data monitoring committee, a separate patient advisory group. You'll have patient reps involved in patient-centered input within the trial, ensuring that the patient voice is heard through the conduct of the trial, and they have an equal say and an equal part in the collaboration of the project. And then administrative staff, ensuring that support is there throughout the trial. So lots and lots of people. The bigger trial, the more people. Maybe for a PhD, some of this might be undertaken by you as an individual, but always it's part of a team. So the primary aim of my trial was to establish the feasibility and acceptability of conducting a definitive randomised controlled trial, which will ultimately look at the clinical and cost effectiveness of this kneecap intervention compared to usual physiotherapy. So we had quantitative objectives. So can the intervention be delivered in an NHS setting? What are the most appropriate outcomes? Can we collect valid and reliable data? And the data that we do have, can it inform a future sample size? And then an embedded process evaluation qualitative component. Is the intervention acceptable and tolerable to participants? Is it feasible to recruit participants? What are the potential barriers? And what's the evaluation of the treatment package delivered to physiotherapists? So feasibility thresholds. So these are thresholds that you set at the start of the trial that you have agreed through all the stakeholders that would show that the trial is feasible and would be a sort of a green light to continue to a full randomised controlled trial. So I needed to recruit more than 4 participants a month. We needed to consent more than 75% of the participants recruited. We needed to have more than 75% of adherence to appointments. We needed to achieve more than 75% of retention in terms of the outcome data. Of that data received, we needed more than 75% of it completed, and we needed more than 75% of the participants to adhere to the intervention. So I recruited participants with patellofemoral pain, aged 18 to 40 years old, with a duration of 3 or more months of pain. I recruited 30 participants into the intervention group. So they had the exercise, the self-management advice, and the pain education. And we compared that to a control group having usual physiotherapy. And the outcome measures used were collected at baseline, 3 months and 6 months. And we collected pain on a visual analog scale, the fear avoidance kinesiophobia scale, the pain catastrophizing scale, pain self-efficacy scale, and then quality of life on the EQ5D scale. This was done recruiting these participants about 2017, 2018 into this trial, and the outcome measures were paper-based. So I printed off the outcome measures with a stamped addressed envelope and posted it out to the participants at 3 months and 6 months for them to complete, old-fashioned paper and pen, and then put it in the post box and send it back to me. So recruitment rate, we recruited 5 participants a month in Derby, and our baseline characteristics are here on this table. 100% of our participants were randomised, and we mostly produced equal equality within the outcome measures. Was slightly more longer duration of knee pain in the intervention group, and slightly worse health VAS scores in the EQ5D in the intervention group. And then in terms of the flow, as I say, we randomised 60 participants at 3 months. In the intervention group, we lost 21 to follow up, and then in the control group, we lost 12 to follow up. And at 6 months, we lost 21 to follow up, and we lost 14 to follow up. So our overall retention rate was 45% at 3 months and 40% at 6 months. Of the data back, it was complete, 99% or near 100%. But what I got back was very low. So my top tip is for this particular element, I actually shot myself in the foot a little bit. So the intervention group was primarily focused on self-management and early discharge. So by 3 months, the vast majority of the patients had been discharged. And by 6 months, all the participants had been discharged from physiotherapy in the intervention group. But in the usual care, all the participants were still under physiotherapy care at 3 months, and the majority, over 50%, were still under physiotherapy care at 6 months. And what I noticed was that I was getting quite a low return rate of my questionnaires. And so I ran around all the physiotherapists and I printed off extra paperwork. And I asked them to, and I gave them to the physiotherapists, and I said, "Oh, when you see your patient, their 3 months, their 6 months, has arrived, please can you ask them to fill in this questionnaire in front of you," which they duly did. I hadn't realised, of course, that it was only the patients in the usual care that were still seeing physios, and I'd kind of, as I say, shot myself in the foot, and I hadn't quite realised that those in the intervention group, although that was the aim of the intervention, early discharge and self-management, they had actually, by 6 months all been discharged, and so that big push to get that extra paperwork back was in the usual care. So not only did I get a low return rate, I got a skewed return rate that favoured favoured usual care and made the intervention look bad. I then tested. We used a free post system within the hospital where I pre-printed envelopes that had a free post system. And I tested it a number of times, and actually the free post system wasn't working. So when I put these envelopes in the post box, they didn't come back to me. So I then phoned up participants to chase up these outcome measures and said, "Oh, have you sent the data back?" And lots of them said they had. Lots of them said they were going to, and then they often didn't come back. So there was a bit of an issue with this sort of a free post Royal Mail system that we had at the hospital. Nowadays, post-COVID, everyone does outcome measures electronic. So a top tip would be cost into your projects, electronic data capture, text messages, emails, chase up with telephone calls. I was phoning the participants up to chase up these outcome measures, and I didn't have in the protocol that I could have collected the data over the phone. And it was only sort of during and afterwards I thought, I could have collected minimal data set or some of the data with the participants on the phone. It purely had to be paper based. So that was a big problem and a big area. In terms of resource and study management, so we did an analysis of the physiotherapist notes to look for delivery of the intervention, so fidelity. Were they delivering the intervention as they meant to? So of the 30 participants, how many of the physiotherapists specifically said in their notes that they gave some education on pain, they taught an exercise, or we call it a loaded exercise, an exercise that was meant to be painful, and did they deliver self-management strategies? So we had a fertility rate of 95%, and then of usual care, the physiotherapists delivering usual care, did they not deliver that intervention? And so we had a really good, it's called contamination. So did the intervention leak into usual care, which it didn't? So that was a good element of the feasibility trial. So if we compare the results back to the feasibility thresholds, recruitment and eligibility, did I recruit more than 4 a month? Yes, tick. Did I get more than 75% consent rate? Yes, tick. Did they adhere to the appointment? Yes, 87%. Did I get more than 75% retention of data? No, it was 42%. But of the data I got back, it was complete, and the participants adhere to the appointments. So some of the feasibility thresholds were met, but one didn't. In terms of the actual data, the global rating of change, which we looked at. So I asked participants on a scale from completely recovered to worse than ever, how is your pain and symptoms now? We dichotomized to those that are saying they were completely recovered or strongly recovered. We classed those as responders, and so at 3 months, 44% in the intervention group were responders, and 56%. Apologies. 56% for 6 months in the intervention, compared to 39% in the control at 3 months and 56%. I then did a sensitivity analysis where I then also included those that were slightly recovered. So for the intervention group, it was 100% were responders at 3 months compared to 78% at 6 months. And then in the control, 78% compared to 88%, so fairly comparable for the global rating of change. I looked at the other outcome measures. So pain, this was where actually the data looked slightly more favourable for the intervention. We had better pain scores at 6 months in the intervention group compared to the control on a scale of 0 to 10. So with great 1.2 in favour of the intervention compared to the control. Same for kinesiophobia. There were better kinesiophobia scores in the intervention group. Better pain catastrophizing scores in the intervention group compared to usual care. Better self-efficacy scores in the intervention group, and better quality of life scores in the intervention group. But within the caveat that this was a low sample size, it wasn't the sample size was not powered to detect a significant difference, and indeed those results didn't show a significant difference, but there was a trend in favour of the intervention. So a process evaluation, barriers and facilitators to the intervention, which was aimed to assess those second parts of the objectives of the trial. I'll just wait a second and let you read the cartoon. So I think this cartoon is a really good example of showing why qualitative data is needed. Quantitative data is really good at showing, from a numerical point of view, what works, what doesn't work, what are the outcome measures, how well are they. Doesn't tell you why or how, what the impact is on the participants or the physiotherapists. We can use qualitative data to sort of test and explore. Sorry, quantitative data to explore sort of efficacy and effectiveness. But qualitative data, questions and interviews with participants to sort of explore the reasons why and understand what went on in a trial. So I interviewed participants. I interviewed participants that had the intervention, that had usual care, that were responders or non-responders to the intervention, and there was a push to interview participants that had failed to attend physiotherapy and even failed to attend the outcome measures. So I asked them about their response to treatment. I asked them about their thoughts and belief about pain, belief and attitude to physical activity, their expectations, and what they thought of the trial and the trial processes. I interviewed physiotherapists delivering the usual care, delivering the intervention. I asked them what their usual practice was, how it compared to the intervention, what their personal development was from taking part in the trial and receiving the training, their thoughts on exercise, particularly around pain and exercise and their attitude towards pain, their belief around physical activity and pain and chronic pain, and again, what they thought of the trial and the process of the trial. A thematic analysis was conducted to look at patterns and themes within the data. What it showed was that there was a large shift in what we call the locus of control. So there was a big push within the intervention for the participants to take ownership and take control of their rehab, to self-titrate was the phrase we used, but self-dose, to self-treat their rehab, their exercise, their activity levels, and there was a big difference within the participants in the interviews that had the intervention compared to usual care. There was a big difference in participants' belief around pain and exercise and contemporary models of pain within the two groups, those that had the intervention and those that had usual care. There were big differences in treatment expectations, participants' attitude to fear avoidance, catastrophizing, their thoughts and expectations for the future in those that had the intervention compared to usual care. And there was again a big shift in engagement with activity and exercise with the intervention compared to usual care. And the physiotherapists themselves described how they went on a little bit of a journey with the training and the sort of the difference in this treatment model compared to usual care. So some stark differences within the qualitative data that perhaps wasn't shown in the quantitative data. And particularly with the negative consequences of having the low return rate of outcome measures and the sort of the uneven return rate of the outcome measures. So in conclusion, really from the qualitative, the clinicians, they were engaged with the intervention, it was 90% fidelity, and this idea that actually physiotherapists were reluctant to get their patients to do something that was painful. They were fairly happy to after receiving the training, and the same with the participants. Actually, this idea that getting participants in pain to do exercise and activity that actually temporarily might aggravate their symptoms, they were fairly happy with, fairly engaged with, and showed actually better adherence to exercise and activity. With greater locus of control, greater self-efficacy. So some quotations from the participants. So this idea of again, getting a participant to do something that's painful when they're already in pain. One participant said it was empowering. One participant said, oh, actually, when I hit the target, I thought, oh, I can actually do this exercise. It is, I can do a few more. It is comfortable. That sense of just how much progress you made. And one participant said, it's that change in mindset that says I can still do these things. I'm not shying away from getting stuck in and being active. So some really, really positive, really, really engaging quotes from the qualitative research, all on the background though of difficulty getting my patient-reported outcome measures back from the participants pre-COVID with sort of paper-based collection. So sort of in conclusion, I suppose, proof of concept, yes, the intervention was delivered. Yes, it was delivered as expected, with good fidelity, with good adherence, with patients saying that it was feasible and acceptable, but with a loss to follow up. I've got to say, I asked the patients to fill in a paper-based diary, which of course they didn't do. Who would fill in a paper-based diary daily for 6 months? Silly of me to ask them to do that. But this idea that they would fill in this paper-based diary box to send it back to me was perhaps a bit naive. And it wasn't done. And so this idea that I've been now trying to write grant applications for future trials, for maybe a full randomized controlled trial on the back of this one feasibility component and threshold that I didn't get, has proven really difficult. At Derby, we've had three or four other AHPs do NHR-funded feasibility trials, and thankfully they've learnt from my mistake and are not doing anything paper-based. They've costed into their projects electronic databases with emails, with text messages to facilitate, to sort of automate the data capture so that participants can do it on their phone, on the computer. They've written into the protocol telephone calls for minding participants to maybe go through the outcome data with the participants on the telephone, to get maybe minimal data sets, so just your primary outcome measure. Maybe asking just the participants just to give the primary outcome measure over the telephone, so you have minimal data set at your primary endpoint. So the endpoint I was aiming for, which was 6 months. Again, the interviews that I did were all face-to-face. They were pre-COVID. The idea of doing an interview over Teams or Zoom didn't occur to me, and so it was all done face-to-face. The participants had to drive into the hospital to meet me. So again, we've thankfully everyone's learned from my mistake, and we can now do interviews over the telephone, over Zoom. So the burden on the participant is much less. And engaging with participants, is proven a lot better, than what I did, back pre-COVID, and back when I got the participants to have to drive all the way in to meet me for an interview. So that's a quick, rundown of my trial. Hopefully, giving you some tips on some of the practicalities of running a trial in the NHS, and some of the trial methods and what needs to be involved. Some major pitfalls that I did. Hopefully, nobody else will. I'll stick around if anyone's got any questions.
Lovely, thank you, Ben. Really insightful, reflexive, and honest experience. I think it's really helpful to people to know that actually it can sometimes be really tricky, and there are some things that go wrong that actually every researcher reflects on and thinks, I'll improve my practice going forwards. I wanted to give some tips about what some of our ARC research teams use for trials. So you said, there are online databases, there are text messages. Our researchers tend to use REDCap and a text messaging system called Flow, which sends reminders, but it's expensive. So you have to cost it in to when you put the funding bids in. So off the top of my head, I think REDCap's like £5,000 or something. If you wanted to work with a clinical trials unit, they will either want to be paid or they will want to come in as a co-applicant and get some cash out of it. So I guess it's the whole thing of stuff costs money and people need to be aware of it anyway. But so shall we take any questions? Let me open chat. No questions as yet. I've put a link to Adam's grant writing YouTube session in the chat. Patricia's put the programme for the rest of the Lunch and Learn session there. But so yeah, anybody have any questions for Ben over and above what he's said already? Excellent. Please go ahead. Go ahead, please.
Hiya, Ben. Great talk. Thank you very much. You summarised things really kindly for us novice. So the question really was about You mentioned about feasibility, and I just wondered what kind of hand-holding you had to kind of bring that all together. You've obviously developed this knowledge and skill over time, but who were the key people who supported you during that application process?
Yeah, thanks, David. Yeah, so you've got to hook yourself up with, make friends, and find people who are interested in your research, who have far more experience than you. So I worked with and collaborated with Professor Pip Logan, who kindly agreed to be my supervisor and mentor through my PhD and my subsequent sort of postdoctoral trials, who is far more experienced than I, who met with me on a regular basis in the writing the grant process, where you would start to draft what the protocol would look like, through the development of the protocol once we got the grant, meeting me on a regular basis, almost as a real handhold and supervisor through that process. And she had a wealth of experience of big randomized controlled trials, multi-center randomized controlled trials, and feasibility trials. So she was my main point of contact, but some of it was also reading around. So reading UK NHS published, NIHR funded feasibility trials to look at common methodology, common trial design, to look at how things were conducted. But it's a team of mentors and supervisors.
It is. I think find someone good and keep them is the real thing about that. We've kept Pip so much, she's going to Australia. But yeah, I mean, in each different part of the country, there will be Pips. But actually, there are clinical trials units. There's the research support service, which is an NIHR service, which it used to be kind of regional, is now national, but there are still regional offices. So there will always be people to reach out to and go and network, and they can put you in touch with some key people. I think if you can also find ex-members of NIHR panels that have assessed trials, that's always really helpful. They can't normally talk to you if they're on a panel, but actually once they've retired from that panel, the ones that we know are normally pretty open about being critical about what you shouldn't do, if nothing else about telling you what you should do. Have we got any other questions or comments, reflections, pleas for help? No, we don't. So we shall stop. So thank you so much, Ben. Really informative run through, really, really valuable. I know everybody is very, very thankful for the time that you have shared with us today.